Hi and welcome back all of you. So the next chapter we are going to discuss in oral pathology is the dermatological lesions of oral cavity, a very important chapter of which some of the lesions are the most important. Okay, so I'll discuss the most important ones and the remaining I'll give you as notes. Okay, because it's a very lengthy chapter. So if I start discussing each and every lesion, what happens is that it becomes a very long lectures. So short ones I'll give you as notes, the long ones I'll discuss it here in different parts. Okay, it will never get over in one lecture, it will take multiple lectures. Fine. So the first dermatological lesion we are going to discuss is ectodermal dysplasia. The name itself, the ectoderm is dysplastic, we will see. Okay, so now affecting the ectodermal derivatives. So in anatomy, you would have studied ectoderm, mesoderm and endoderm, and you would have studied ectodermal derivatives also, from what all structures comes from ectoderm. So these structures are affected. You will see nails, skin, the salivary glands, the sweat glands. These are the structures which get affected here. Okay, so affecting the ectodermal derivatives. And inheritance is important. Now see, in oral pathology, they could ask you, as well as general pathology, they could ask you the inheritance pattern. So you have to learn them. It's not important to learn each and every inheritance pattern. No, there are some important lesions which you have to learn. Now here, there are different inheritance patterns for all the diseases. It's not like a disease has got a typical inheritance pattern. No, there can be multiple. Okay, and you would have studied the inheritance patterns, understanding the genetics in general pathology. So it's a kind of, you'll understand it better now. So here, inheritance pattern, the most common inheritance pattern is X-linked recessive. Okay, X-linked recessive. So X-linked dominant is there, X-linked recessive is there. So recessive means what? Females are carriers. You would have studied it, isn't it? And males are majorly affected. Okay, now see, clinical features. So it's the most common. Okay, you will see other inheritance patterns also when you come up to the different types. So clinical features, what you have to note here is there are two types. Okay, there are two types of ectodermal dysplasia. Okay, very important. The first one is hypohidrotic. That means decrease the sweating. That is hypohidrotic, decrease sweating. That's the most important feature. Okay, where sweat glands are affected. Or anhidrotic. Okay, anhidrotic means again there is no sweating. Okay, now it's got a different name which you have to know. That is the Christ-Siemens-Torrance syndrome. Christ. Okay, very important. Christ-Siemens-Torrance syndrome. Okay, that's a hypohidrotic. Okay, hypohidrotic. There is one more type which is hydrotic. So that means there is sweating. Okay, the sweat glands are not affected majorly. So that's hydrotic. Also got another name which is the Clauston. Okay, Clauston. So the first one is Christ and this is Clauston. Okay, Christ and Clauston, that is anhydrotic, hydrotic. Don't get confused. See, you learn one, the other is opposite. Don't learn both. Okay, if you like, for example, you are learning like hypohidrotic is Christ, that means hydrotic is the other one. Okay, which is Clauston. Fine. So that's the trick you use when there is a possibility of confusion. Learn both, but remember one. Okay, the other one is the exact opposite. I've been saying this multiple times now. So hypohidrotic and hydrotic. Okay, hypo is same as an. Okay, now few things you have to note here. The first one, it is the most common phenotype. So we said there are two types. So this anhydrotic is the most commonly seen one. Okay, or the Christ-Siemens-Torrance syndrome is the most commonly seen one, the most common phenotype. They can ask you this. Okay. Now it's X-linked recessive, definitely. We said that's the most common inheritance pattern. Now in this X-linked recessive, it's XQ arm. Now you know XQ and XP now, isn't it? P is petit, B is the longer arm. So XQ is affected. Okay, XQ is affected and it is a gene encoding for ectodysplasin. Okay, now oral pathology is shifting more towards histochemistry. Okay, and the genetics. Majorly the questions come from there. Okay, so you have to learn them. So ectodysplasin, XQ, ectodysplasia. That's the one which is associated with anhydrotic. Okay, XQ, ectodysplacing. The protein S or gene encoding for the protein ectodysplacing. Okay, you know now genes, transcription, translation, proteins are formed, isn't it, in biochemistry? So that's what it is. Now, what are the features? The features, very, very, very important. Okay, there are different structures, as I've told you, ectodermal structures are affected. What are they? One is glands are affected. That's why the name in itself, isn't it? Anhydrotic, sweat glands. Okay, then nails are affected, another ectodermal structure. Hair is affected. Okay, I'll show you the pictures. Dental, definitely, ectodermal, isn't it? Then face. Okay, ectodermal structure. So what are the structures affected? Glands, nails, hair, dental, face. Okay, so let us see one by one. What are the glands affected? The most important gland which is affected is the sweat glands. Okay, the most important gland affected is the sweat glands. Now, what happens? Hypohidrosis or anhidrosis, there is no sweating. That is, I've seen a patient recently having this particular syndrome, and he said to me that most problematic thing for me is I feel that real very hot. Okay, especially in summer. What he does is every 1 hour, every 1.5 hour go and take a bath. So we should be thankful to God that we don't have such problems. Just imagine every 1 hour, every 2 hour go and pouring water on your body. How difficult it's going to be, isn't it? So sweat glands are most commonly affected, hypohidrosis, and definitely salivary glands. Okay, salivary glands, but the thing is that it's least affected. Now, when there is xerostomia, what is going to happen? Caries. Already you will see that there is hypodontia, very little teeth the patient has. Okay, plus there is xerostomia, due to which there is a possibility of caries, so that also goes for extraction, and finally the patient ends up in denture. Okay, the patient ends up in denture or implants. Okay, so that's the importance of this patient and dentistry. Okay, this patient can come to you. Ectodermal dysplasia patient can come to you for dentures. Okay, or implants or caries also. So now there's the first structure, glands. When it affects the nails, it has got a typical name which is known as onychodysplasia. Onycho means nails, dysplastic. Okay, ectodermal dysplasia in itself. So onychodysplasia, very deformed nails. Okay, then when it comes to hair, it is hypotrichosis. There is very little hair, hypo. Okay, and again, there's a typical feature, light, fine hair. You can get this in the questions. A patient with this and this features with light, fine hair and all. So you have to guess it like it's ectodermal dysplasia. Definitely they'll give you more features. Okay, anodontia, hypodontia, peck-shaped teeth, all those. Okay, definitely sweat glands are, if it is anhydrotic. Okay, so then we come on to the dental features. Again, very important, of which the most important is hypodontia, anodontia, oligodontia. That means you know the terms now. Basically, decreased number of teeth. Okay, anodontia means there is no teeth. Okay, we have studied this, what each term differentiates. Okay, so I'm not going to repeat it here. Now, peck-shaped or pointed teeth. That's very important. That's what you will see in the images. I'll show you this. Okay, in the image-based questions, you will see this type of teeth. Okay, and then features will be there which will help you to differentiate. High arched palate. Okay, and definitely cleft palate. So some patients will present with cleft palate. Okay, again dentistry associated. So now those patients with the cleft palate, this question has been asked. Okay, which is the gene affected? That means those patients with ectodermal dysplasia plus cleft palate, the gene is different. Okay, the gene is different. It is the gene which is PVRL1 gene. Okay, just remember this gene, PVRL1 gene. So they will ask you the question, that is, in patients with ectodermal dysplasia with cleft palate, which is the gene affected, and they will give you different options. Okay, they can even give you the gene encoding for ectodysplasia. No, it's PVRL1 gene. Okay, it's PVRL1 gene. Okay, now when you come on to the face, the features of the face, frontal bossing. Okay, frontal bossing. I'll show you one of the image. Okay, which shows a little bit of it. Then saddle nose. Okay, saddle shaped nose, which is very evident in the very important feature. Now they'll give you this in the options. Okay, in the questions. Okay. in clinical based questions. Wrinkle, hyperpigmented skin around the eye, a very typical feature which you can see in this patient. Okay, I'll show you the image again. Protuberant lips, lips are protuberant. So this features I'll show you in one of the image below. Before going further, see the lips which are protuberant outside, isn't it? This patient has got lips which is protuberant, a little bit of frontal bossing. You will see a typical feature of this. Almost all the patients will have these features: frontal bossing, a saddle-shaped nose. See this nose here. Okay. Then there is the peck-shaped teeth. Okay, the peck-shaped teeth there. Okay. So this is the typical features of anhydrotic ectodermal dysplasias. Okay. So again, the other picture also the same. Now, if you come on to the hydrotic form, that is the Clauston syndrome form. The Clauston syndrome. The other one was Christ-Siemens-Torrance syndrome. At least remember Christ. Okay. This is Clauston. So hydrotic. Now see, this is no answer is in front of you, isn't it? Even if you remember Christ, you will remember the rest when you see the option. That's how you learn for NEET MTS. It's not like what you do for your BDS examinations. You don't need to learn everything. It's called smart study. Okay, you don't need to stress yourself by remembering Christ, then what? Christ, then what? Then what? No. If you have seen it, if you have developed the photographic memory, even if you learned Christ, the rest will come to you. Okay, so it's hydrotic, Clauston syndrome. Okay, and where you will see normal sweating. So it's exact opposite, hydrotic, no? No dental defects, no anodontia, no peck-shaped teeth. Okay, no peck-shaped teeth. Normal facial features, that's why I told you the other one was typical features of the anhydrotic form. Now, so what are the features now? There is no sweating, or I would say there is normal sweating, there is no dental defects, there is no facial problems. So what are the features you will see? One is the first one which you have to know is inheritance, autosomal dominant. The other one was X-linked recessive, exactly the opposite. X-linked recessive. Here it is autosomal dominant. But again, if they ask you the question, which is the most common type of inheritance, it is X-linked recessive only. So that means autosomal dominant means now the gene will come. It's not X, isn't it? So which is the gene? It's 13q. The other one was XQ. Now it is 13q. Okay, the other one was ectodysplasin. It's 13q. Now the gene, the chromosome is 13q, the gene is GJB6. Okay, it's not PBRL1, it's GJB6. Okay, it'll come, it'll enter. Okay, while revision, it'll enter. Don't worry. Don't think that, okay, I'll forget it. I've seen students saying that, so yesterday I studied very well. I wrote the notes, everything I did, but I forgot today. That's what is called entrance examination preparation. Okay, you have to develop the photographic memory. You have to definitely revise them. Okay, and this is again the protein here is connexin, not ectodysplasin, connexin 30. Okay, so it's very important. The first difference is autosomal dominant. The gene is JB6, it's 13q, and connexin 30. Now, clinical features: nail dystrophy is there. Hair defect is there. Majorly, you will see this. Hair defects and nail dystrophy. Okay, the other features are not very prominent, and luckily for us, it's rare compared to the other one. Okay, so that's the clinical features. So just going for the differences, once again a quick review. The Christ one is the most common one, and where it's XQ ectodysplasin, isn't it? And you will see all the glands, okay, which is affected, which is much more important. Okay, then dental defects are very typical: hypodontia, anodontia, and yes, cleft palate is there, where gene which is affected is PVRL1. Facial features are very important here: frontal bossing, saddle nose, wrinkled, hyperpigmented skin around the eyes. Now this patient, you will see it. See this. Okay, it's hyperpigmented, a little pigmentation here, isn't it? In hyperpigmented, wrinkled skin. Now, this is not a very, you can't diagnose a patient based on this, definitely. You will see many other patients also, people also with this kind of a feature. But yes, this is, if you find other features, this is also will be there. Okay, protuberant lips is very important. So saddle nose and protuberant lips are the most important thing we have to note here for a clinical question. Okay, besides the other ones. Hypohidrotic, no such problems, normal sweating, no dental defects, normal facies. Okay, now here the gene is very important, which is the GJB6. 13q chromosome, and it connects in 30. Okay, there is nail dystrophy and there is hair defects. Now, what's the dental consideration for this patient? The patient is denture patient. Okay, the patient is a denture patient. Okay, so this is what it's all about, ectodermal dysplasia. Majorly, just remember the ectodermal derivatives are affected. Autosomal recessive, what are the genes? But there is autosomal dominant, there is X-linked recessive. Okay, it's X-linked recessive and there is an autosomal dominant form, isn't it? So ectodysplasia and connexin 3, but in cleft lip and palate, it is the PVRL1. There is no dental defects in the second type, Klumpstone syndrome. Christ, there is dental defect, there is facial problems. So if you know this much, you have done a good job of the ectodermal dysplasia. Now see, this is a typical peck-shaped teeth you can see here in the radiograph, isn't it? In the radiographic picture, you can see here there is a peck-shaped teeth. Now, they can ask you image-based questions based on this. Now, people worry, how will I diagnose this from this picture? One thing you have to do is, you have to see. So, the typical feature you can see here is what? Anodontia, or I would say hypodontia, not anodontia, there is hypodontia. So what are the features, you have to diagnose it this way. What are these diseases which is very typically, with hypodontia? Most important is definitely going to be, there is hypothyroidism and all, but is the most important is ectodermal dysplasia. Just see the options. Okay, if in the option there is ectodermal dysplasia, jump onto it, even if there is other options also, because the most common feature or the most common disease with hypodontia is it. Now, few more things. Mostly, they won't give you this image alone. Most commonly, they will tell you the patient is having hypodontia, anodontia, sweat problems, okay, problems with sweating, onychodysplasia, some features which you are very familiar with, plus this image, so it's not going to be a problem. Okay, so that's the first lesion we have studied in the dermatologic lesions. Now, dermatological lesions can be divided into non-immune related and immune related diseases. So this is the most important non-immune related disease, which is ectodermal dysplasia. There are a few more, which is small ones, which you can study from the notes. But now let us go on to the immune related, okay, immune mediated the disease of the skin, okay, or dermatological lesions related to the oral cavity, of which the most important, and this is okay, immune related disease is much more important than the non-immune related disease, okay. And here we come across pemphigus, pemphigoid, lichen planus, then erythema multiforme, then SLE. All these lesions are important and I'll be teaching you them, okay. Now pemphigus, very important. This is an IgG, you know IgG now, microbiology, isn't it? IgG antibodies against. Now see, when I see IgG, now don't think that I forgot the third line or I forgot the entire thing. No, the things will come when you are solving MCQs, don't worry. But you know what is IgG now? Imagine people who are doing self-preparation, they might not be knowing what actually immunoglobulin is. Okay, what is the basics of immunoglobulin, they might not be knowing, but you know now. That's more important. You know what is IgG. Okay, you might not be aware of this. Students who are doing self-preparation, they just simply muck up their dental pulse or dentist or Neeraj Wadhwan and think that they are doing it perfectly. No. So IgG antibodies against cell surface keratinocytes. We studied it in periodontics, isn't it? Keratinocytes. It's a type of epithelial cell, keratinocytes, which produces keratin. Okay, so definitely, if we study it in perio, there will be oral manifestations, isn't it, of this? And yes, pemphigus is very much involving the oral cavity. Unlike the other lesions we're going to see, especially pemphigoid, it is less commonly involving the oral cavities. Okay, now there are different subsets or subtypes of pemphigus. Okay, so they are divided into 4 major types and some related disease. Okay, so one is pemphigus vulgaris, which we could discuss, the most important, which is pemphigus vulgaris. You know it. Pemphigus vegetans, we'll discuss a little bit on that. Okay, these are the 2 lesions which is involving the oral mucosa. Then we also have pemphigus foliaceus, means leaf-like. Okay, pemphigus foliaceus, and then you have got pemphigus erythematus, reddish. Okay, pemphigus erythematus. Now that's the 4 types, major types: vulgaris, vegetans, VV, foliaceus, erythematus. Okay, or erythematosus. Then you have got paraneoplastic pemphigus, which is a related lesion. I'll tell you what it is. Okay, paraneoplastic, and you also have got chronic benign familial pemphigus. So familial, the term here is very important, and it's called Haley disease. I'll discuss these two here itself, and we'll go into details of the other ones below. Okay, so it's Haley disease, which is chronic benign familial pemphigus. Now, coming on to the pemphigus vulgaris, the most important thing you have to know here is it's the most common type of pemphigus. It's the most common, that itself is an MCQ, which is the most common type of pemphigus. And another thing is, these two, vulgaris and vegetans, are the ones which affect the oral mucosa. They can ask you in this way also. Okay, now, foliaceous, I'll finish these also here. Foliaceous, few things which you have to know. Vegetants I'll go into, because these are the two ones, vulgaris and vegetans I'll go into a little bit of details, because these are the ones which affect the oral mucosa. But foliaceous, few things you have to know. Foliaceous means Brazilian pemphigus. They can ask you other name, which is Brazilian pemphigus. So it's the foliaceous type, okay, which is a Brazilian pemphigus. Then you have got another name, Brazilian wildfire. Okay, Brazilian wildfire, the other name, or superficial pemphigus. They can ask you that also. Superficial pemphigus, which is it? It is the foliaceous type. So it's Brazilian pemphigus, Brazilian wildfire, superficial pemphigus, which is the foliaceous. Okay, so write it down there. Erythematus is not much. If you just know that it's erythematus, reddish. But let's come on to the paraneoplastic. Okay. Basically, it's a pemphigus-like lesion. Pemphigus-like lesion in those patients taking certain medications. Now, is it important for you? Though it is not affecting oral mucosa, yes, it is important for a dentist. Why? Because, okay, now we give some drugs which can cause it. So, penicillamine is basically an immunosuppressive drug, which is not, we are not bothered about penicillamine. Okay. AC inhibitors, again, we are not bothered about. It's used in basically for hypertensive patients, AC inhibitors. Okay, NSAIDs, don't we prescribe too much of NSAIDs? Yes, we can induce this type of pemphigus, which is paraneoplastic pemphigus, which is pemphigus-like lesion. Okay, we can induce them. In some malignancies, and most importantly, they can ask you a malignancy, which is CLL, chronic lymphoid leukemia. We'll go into detail of leukemias in general medicine. Okay, so CLL. So most important thing we have to know here is paraneoplastic pemphigus is a pemphigus-like lesion in those patients taking drugs like penicillamine, AC inhibitors, NSAIDs, and malignancies, majorly CLL. Okay. So that's majorly what you need to know about paraneoplastic pemphigus. Now let us come on to the chronic benign familial pemphigus, or the other name is very, very important, Haley disease. Family Haley. Okay, that's how we can remember. Benign familial, chronic benign familial pemphigus, or Haley disease. Now, what is the difference between this disease and the normal pemphigus? That's what we're going to see. One is, it's an erosive cutaneous lesion. It's much less vesiculobolus. Okay, pemphigus has vesicles. Okay, eruptions. This is erosive cutaneous lesion. This is erosive, erosions, deep. Okay, it goes deep, erosive, and causes more commonly ulcers rather than vesicles. Definitely pemphigus also, the vesicles break and lead to ulcerations, but here it's typically erosive and ulcerative. Okay, now another thing which you have to know, no oral involvement. Like the pemphigus vulgaris and vegetans we saw, there is no or very little oral involvement. So it's not important for you as a clinician, but it's important for you as a NEET MD's aspirant. Okay, they can ask you Haley disease. Strong familial history. Why? Familial Haley. Okay, strong familial history. Also, the type of pemphigus, they can ask you, even if it's a related lesion, they can ask you the type of pemphigus which is having a strong familial history. What's that? Haley disease, or chronic benign familial pemphigus. They won't ask you chronic benign, it will not be their chronic benign familial pemphigus, because the question itself is a familial, okay, which is the most common, which has got a familial involvement. They'll ask you the option, and there will be Haley disease. Now, histopathologically, very typical, dilapidated brick wall appearance. Okay, that is two bricks, okay, arranged in a pattern. You don't need to go into the histopathology, just know the name. They can ask you dilapidated brick wall appearance. Now, you're studying from synopsis. Just imagine you're studying these things from synopsis, and you're studying these things as a notes in a systematic way, which is much more easy for you to remember. Definitely this method. So that's why we tell you, like, see, the synopsis of oral pathology is very, very difficult to learn, almost impossible to learn. And yes, to be frank with you, I haven't learned it. Okay, I tried to, but it was not possible, so I left it. And yes, I got it. Even then I got it. So you can also make it possible. But one thing is, you have to learn the notes. Okay, you have to learn the notes properly. Because it's in a systematic way, it becomes much more easy. But learning the synopsis, but read, if you have time, definitely I would recommend to read it, because lots of information are there. Okay, but don't think that I learned synopsis and not learn notes. No, it's other way around. Dilapidated brick wall appearance. Okay, so erosive, no oral involvement, familial, dilapidated brick wall appearance is the most important. So that's about the different types of pemphigus. Okay, vulgaris, vegetans, foliaceous, that is Brazilian, erythematosus. Then you've got paraneoplastic and Haley. Now let us come on to the first most important pemphigus, which is pemphigus vulgaris. Okay, now what is you have to know? It's a vesiculobullous lesion, definitely. Okay, vesicles and bullae. I'll come to this. What is vesicle versus what is bullae of skin and oral mucosa? These are vesiculobullous lesions of skin and oral mucosa, understandably. Now, clinical features, very, very, very important. Typical features, I'll tell you. Now, the first thing, or structures in what? Oral mucosa, skin, and ocular a little bit. But note here, pemphigus, the ocular involvement is much lesser. Here it's basically oral mucosa involvement, pemphigus. But when you come on to pemphigoid, it is less oral mucosa, more dangerous involvement of ocular region, eye region. Okay, so that's the third one is eye, oral mucosa, skin, but eye is less significant here. Okay, so oral mucosa, you have to know very, very important few things. 95% cases, that's why I told you. As a dentist, you should be very aware of this lesion. 95% cases of pemphigus will have oral mucosa involvement. That means only 5% out of 100 patients, 95 patients will have oral mucosa involvement. Okay, so if you're planning to take oral medicine, okay, think of it. Okay, you will see lots of them. Now, 50% cases, 95% involvement is a 50% cases, it's an initial presentation. Okay, now unfortunately for us, oral medicine specialists still go and do restorative dentistry. They think that clinical, okay, without clinical job, I can't survive, so I'll start my clinic. They are not aware of this. Now, who will this patient go to then? They'll go to the medical practitioner. But if oral medicine was a specialty and was given the due importance to it, okay, then it would have been done, or I would say our specialty in itself would have changed in a different way. Okay. Anyways, fine. 50% cases, it's an initial presentation. 50% cases. Okay, they won't have anything related to skin or ocular mucosa. They just have oral lesions. Okay, so many of the ulcers you see, which you think that it's a normal ulcer, could be a pemphigus. Okay, now very typical description of this lesion. First to show that is oral mucosa lesions are first to show that is 50% cases are initial presentations, and last to go. Even after a very good treatment, this oral lesions will not go, skin lesions will go, oral lesions will not go. That's a big problem. Okay, first to show, last to go, which is it? Pemphigus vulgaris. Okay, 95% cases. Okay, and now what's the lesion like? We said oral mucosa lesions are very, very significant. So how is it? You can see vesicles. You can see erosions, which can get into ulcerations. Basically, erosions and ulcerations are very similar, but It's much more deeper, you see erosions. Okay. Now vesicles are rare. That's what I told you. You will not get a patient with pemphigus which comes to your clinic, initial presentation with a vesicle. Mostly you will see that it's erosions and ulcerations. Okay, mostly you will see erosions and ulcerations. So pemphigus vulgaris is one thing which you have to be very aware of when a patient presents to you with ulcers and erosions, deep ulcers and erosions. Okay, deep ulcers and erosions, not the typical one ulcer here and there. No, I'll show you the images out there. So vesicles, erosions and ulcerations. So that's the oral mucosa findings. Now when you come on to the skin lesions, you will see that vesicles are more common and bullae. Vesicles and bullae are more common, unlike the oral lesions where erosions and ulcerations are more common presentations. And this vesicles and bullae, as I've told you, could rupture and it can lead to erythematous denuded areas and ulcerations. Okay. Now, one thing very, very important you will see in pemphigus vulgaris and some other lesions, but more importantly in pemphigus vulgaris is Nikolsky's sign is positive. I'm sure you, if you're someone who have started your MDS preparation, you are very much aware of this. Nikolsky's sign is positive. Okay. So, what is basically Nikolsky's sign? That is, bullae can be induced. Okay, bullae can be induced on a normal skin. Okay. Imagine a patient with pemphigus vulgaris. Okay, he doesn't have any bullae, but he's diagnosed with or is suspected to have pemphigus vulgaris. You can induce bullae on his skin just applying firm lateral pressure. Just press lateral pressure with some few hours or days, probably next day also. You can see that vesicles and bullae is erupting. That's called Nikolsky's skin. Bullae can be induced on normal appearance skin if firm lateral pressure is induced. Okay, apply. It's not, currently it is not recommended. You don't want to induce bullae. So this is basically the pemphigus vulgaris cutaneous bullae, as you can see here. Okay, which is the bullous lesions. Now, the next lesion is ocular, eye. We can see the conjunctivitis and which is very rare and no scarring is seen. Even if there is conjunctivitis, you couldn't see scarring. Now, next lesion we are going to see pemphigoid, especially the cicatricial pemphigoid. Okay, or mucous membrane pemphigoid. You will see that ocular involvement is very dangerous and it can lead to scarring. Okay, scarring is there. Here there is no scarring. That's one difference you can typically make out of pemphigus and pemphigoid. Okay, so what we saw. Different types, more importantly, oral mucosa involvement. Keep this in mind. Ulcerations, erosions, okay, and skin lesions, Nikolsky's sign in bullae. Ocular not very significant. So this is what the bullae of it will look like. Okay, this you can see. Bullae has erupted, and it is just you couldn't see that erythematous. So it's not much erythematous. It has become much more violaceous kind of thing. Okay. Anyway, this is what the book says. Now, oral mucosa, see ulcerations. If you see a patient with this kind of an ulcerations, don't think that it is the major. Okay, you have a differential diagnosis of recurrent major. Okay, ulcerations. Okay, recurrent major aphthous ulcers. But you could or you should also suspect pemphigus vulgaris. Okay, so these are the lesions you can see with ulcerations on the oral mucosa. Okay, just see the ulcerations in the floor of the mouth there. Gingiva, this is okay, erythematous region. Okay, marginal gingiva can also be affected. Okay, now you can't get this picture alone. There will be some description saying you are giving you a clue, which is very typical of pemphigus vulgaris. Okay, most importantly, histopathological finding they will tell you, which is typical pemphigus vulgaris. Okay, so coming to diagnosis, we have got perilesional tissue is used for histopathology. Okay, histopathology is the diagnosis or is the most important tool for diagnosis, and use the perilesional tissue, that is not the ulcerated mucosa. Okay, the around, for example, if you have got, okay, this is the ulcer you have. Okay, so you shouldn't be using the area which is that region. You have to use this area, okay, to get the proper histopathology. So that's what they're telling. Okay, probably they might not ask you, this, okay, because much more important things are there. Now, you could see antibodies here. That's very important. Detection of antibodies. I'll tell you how to detect the antibodies, but detection of antibodies is a very important feature of pemphigus vulgaris. Okay, different antibodies are seen, especially against desmosomes of keratinocytes. We said IgG directed against the keratinocytes. Exactly, what of keratinocytes? So desmosomes of keratinocytes. Now, what are desmosomes? Desmosomes are the glycoprotein components which bind the two epithelial cells together. Okay, one epithelial cell, another epithelial cell binding together. So in this lesion, this split happens. That's what we will see. Okay, so they are directed against desmosomes of keratinocytes, which binds the epithelial cells to each other. Now, basically, which component? That is desmoglein 1, okay, which is a component of desmosome, okay, desmoglein 1 and desmoglein 3, not 2, remember that, desmoglein 1 and 2, 1 and 3, sorry, 1 and 3. And see, these are basically what? They are the glycoprotein component of desmosomes, and desmosomes bind the keratinocytes together. Hemidesmosomes, we will see what they are. Okay, you would have already studied it in the periodontics, isn't it? So desmoglein 1 and desmoglein 3 are affected. Okay, or I would say antibodies are directed against desmoglein 1 and desmoglein 3. That's a very important question in pemphigus. We'll come to pemphigoid, we'll see a different set of antibodies directed. So remember, you shouldn't confuse desmoglein 1 and desmoglein 3. Now, these very important, where they are seen. These antibodies against these components are seen in which region of the epithelium? Is it seen on the skin or oral mucosa? That's very important. Now, desmoglein 1 is seen in the superficial portion of epidermis, which means not oral cavity. Epidermis means skin. Superficial portion. So, this is superficial portion and deep portion. So, it's more common in the superficial portion of the epidermis and minimal in oral epithelium. So, that means 1 is minimal in oral epithelium. You will see about 3 in the parabasal region, the deeper region, parabasal region, you will see 3. Plus, it's the one which is seen in the oral epithelium. That's a very important question for you. Okay, if they ask you the antibodies seen in pemphigus vulgaris is what? 1 and 3. But if they specifically target you, asking that in oral epithelium, which is more commonly seen, and if you have to select between these 1 and 3, select 3. Okay, and superficial part 1 is seen, deep part 3 is seen more commonly. Okay, this is the antibodies against the keratinocytes. What of keratinocytes? The hemidesmosomes. What exactly of hemidesmosomes? Desmoglein 1 and 3. So this can be used for the diagnostic purpose. How is it? Basically, you can go for a direct immunofluorescence, you can go for an indirect immunofluorescence, you can go for an ELISA. So, what is immunofluorescence? You would have already studied this in microbiology, I guess. Direct immunofluorescence, where we take the tissue directly, it's not in the blood. You take the tissue directly and we see the antibodies are seen on the tissue or not. If you're taking oral mucosa, perilesional tissue, we detect antibodies in the tissue, not in the blood. That's what it's called directly from the tissue. So you will see that indirect immunofluorescence, which is 100% times positive. Okay, autoantibodies are seen and complement components are demonstrated. Okay, it's not very significant, but these autoantibodies are much more typical. You know now what complement is. This is what I told you. Okay, you know what complement is now. You can learn it. I know you would have forgotten many things about complement, but still you know it. Okay, what it is. Now, in the intercellular spaces between the cell, desmosomes of intercellular spaces. Okay, between epithelial cells. Now, whereas if you come on to indirect immunofluorescence, which we've seen in the blood, antibodies in the blood, okay, which is only 80 to 90% times positive, okay, and you will see circulating antibodies in the serum. So that's the difference between direct and indirect. Direct, you take the tissue, you see antibody there. Indirect, you see it in the blood. You need to take the blood. Okay, which is again not very much positive as the direct one. The third is again ELISA, which is same circulating antibodies in the serum. Okay, so basically what did you learn? For diagnosis, peri-lesional tissues has to be used. Antibodies directed against desmosomes 1 and 3. 3 is more common in oral epithelium. How to detect them? Direct, indirect and ELISA. Direct is 100% positive. You get antibodies on the particular tissue. Okay, and indirect in the serum, ELISA in the serum. So that's the first part of diagnosis. Now we come on to the histopathology. Okay, you take the tissue, you send for direct immunofluorescence, plus you send it for histopathology. Okay, now you see intraepithelial separation between the epithelial cells or intraepithelial blistering because desmosomes are affected. Oral mucosa is affected, very important. That is called a suprabasilar split. Above the basal layer, epithelium, you've got basement membrane, basal layer. So above the basement membrane, or more commonly above the basal layer. Okay, above the basal layer, the down layer. Basal layer, spinous layer, I'll show you in one of the other lesions what they divide into. So suprabasilar. Okay, so it's basically this is the basement membrane there. You will have the basal cells. As it is attached to the basement membrane through hemidesmosome, they doesn't split, but more commonly the cells above that, these are the ones which is affected. So it's suprabasilar split. Okay, that's very important diagnostic feature. So whatever image they give you related to the this particular lesion, pemphigus vulgaris, they will tell you the suprabasilar split. Okay, don't worry. Now you will see that the cells of spinous layer, I told you. So basal layer, spinous layer is there. The cells of spinous layer, which are round cells. Okay, I think yeah, it's there in here. Okay, so this is the basal layer, spinous layer. Okay, so this is the spinous layer. Okay, and above that more layers are there, granulosome, corneum. Okay, but more importantly what we are concerned is spinous layer, which are round cells. You can see there, round cells, isn't it? The cells are much more round. So this spinous layer, the cells of spinous layer which are round cells, they fall apart, they fall away. Sometimes they separately fall away or they entirely go away. So if they fall apart a little bit, then you get what is known as acantholysis. This particular thing is known as acantholysis. That is, spinous layer is falling apart. We get acantholysis, which are round cells. And the name of these round cells are Sang cells. Okay, don't confuse here. So the spinous layer, now there is, desmosomes are affected. So as a result, spinous layer fall apart, which is known as acantholysis. Okay, and this spinous layer cells, round cells, are known as Sang cells. So they can ask you, Sang cells are seen in pemphigus vulgaris. Plus, so now, I don't know if you have learned about exfoliative cytology. If you have not learned it, you will learn it in OMFS. Okay, exfoliation is what is happening here. So there's a method to just recognize those exfoliated cells, which is called exfoliative cytology. Okay, so it is seen, this acantholysis is seen in exfoliative cytology. So that's another method of pemphigus vulgaris. One we saw, direct immunofluorescence and ELISA, histopathology, exfoliative cytology, where you recognize the Sang cells. Now, see, Sang cells are seen in acute herpetic gingivostomatitis also. That is, acantholysis is seen in two lesions. What are they? Pemphigus vulgaris and acute herpetic gingivostomatitis. Okay, so we saw intraepithelial separation. Basically, initially it involves the spinous layer where you get acantholysis. Now it can involve the entire superficial layer just falls away, not just the acantholysis or not just the spinous layer. The entire superficial layer is stripped off. Okay, so in that case you see something known as resembling row of tombstones. Now see this. Yeah, this is it. This is the cleft. Okay, intraepithelial cleft there. So this is the cells, which is the basal layer. So this is a tombstone, raw tombstone. Okay, and this portion is just stripped off, gone away. Okay, this is the clefting. You can see intraepithelial clefting, or you can see here. See, this is the intraepithelial clefting there. Okay, within the epithelium. The cleft is within the epithelium. Okay, I'll show you more images. Yeah, more clear here. This is the, below here is the basal layer, isn't it? The basal layer is still there. Okay, and above that the white region is the clefting. Okay, where the portion is just stripped off. So you can get these images. Again, this is a cleft. Okay, but more importantly, they will tell you that there is a clefting. Okay, suprabasilar cleft. Raw tombstone appearance. Now, finally, when we come on to the treatment part, it is systemic steroids. Why? Autoimmune. It's an autoimmune disease. You have to reduce the inflammation. There is antibodies directed. So you use systemic steroids, usually prednisolone. We'll come to steroids in pharmacology. And we can also use other immunosuppressive drugs. More commonly used is azathioprine. Okay. Now all the autoimmune diseases you're going to see the treatment is this only. Okay. Prednisone, systemic steroids or local steroids. Azathioprine. Okay, for other immunosuppressive drugs. Now, there is newer therapies to suppress the autoantibodies directly. Rituximab. Okay, very, very important. You'll study this in pharmacology again. Okay, in chemotherapy. And there is calcineurin inhibitors also. Just know them. Okay, rituximab, calcineurin inhibitors. So, rituximab is much more important. Okay, so that's about the treatment part. So, what all did we see about in this pemphigus? We saw different types of pemphigus, of which most important is vulgaris and vegetans, paraneoplastic drugs, Early-Haley. Vulgaris, we said it's basically oral mucosa, 95% cases, and it's basically ulcerations, erosion, skin, Nikolsky's sign. Okay, ocular lesions, very rare. Diagnosis on autoantibodies, direct immunofluorescence. Okay, desmoglein 1 and 3, basically desmosomes. So desmoglein 1 and 3, 3 is in the oral mucosa. Then there is intraepithelial separation. Okay, suprabasilar split, Sang cells, acantholysis, row of tombstones. Okay, so that's then finally treatment rituximab and the systemic steroids. So that was pemphigus vulgaris. The next type, important I told you, which is having oral manifestations, pemphigus vegetans. Okay. Now few things about pemphigus vegetans. There is two clinical subtypes again. Okay, which you have to know, that is Newman type. Okay, Newman type and halotype. Okay, halotype. So Newman type and halotype, the clinical presentation is different. In Newman type, you will see the typical bullae or erosions. Whereas in halotype, you see the pustules. I'll tell you what bullae is, what are pustules, what are plaques. Okay, I'll show you with image. Remember, Newman type is there, halotype is there. In Newman, you will see bullae or erosions. In halopo, you will see the pustules. Okay, so halopo and pustules, PP. That's one thing, one way you can remember it. Okay, and Newman is the other one. What is that? Bullae or erosions. Okay, now both of them, how do they have is, they've got a what is there in common? That is hyperpigmented vegetative plaques with pustules. Okay, so initially they'll be presenting as bullae or erosions, that is differently, bullae or erosions or pustules, but later on it becomes similar, that is hyperpigmented vegetative plaques. Okay, I'll tell you what plaques are with pustules. Okay, so this one finally end up in pustules only. This one also end up in pustules only, but initial presentation is different. Okay, so bullae or erosions in Newman type and halotype is pustules, but later on there is plaques which becomes pustules. Okay, so we will see what they are. Now before that, one more thing I just want to add here. There is hypertrophic granulation tissue at the periphery. Okay, not very important. Most important thing what you have to note here is Newman and halopo. Newman has got this, halopo has got this. If you know this much, that's enough. But just for a completion sake, they've gotten plaque, pustule with hypertrophic granulation tissue around. That's it. Okay. Now, much more importantly, very characteristic finding which is called as the oral manifestation, cerebriform tongue. Okay, cerebriform tongue, that is like the brain. Okay, sulci and gyri on the dorsum of the tongue, you will see. Okay, there is cerebriform tongue. So they'll ask you cerebriform tongue, cerebriform, cerebrum, brain. Okay, like sulci and gyri. So they'll ask you cerebriform tongue is seen in pemphigus vegetans. Okay, pemphigus vegetans. Foliaceous was the Brazilian one, superficial one, isn't it? Now it's vegetans. So that's the two things which you have to know here. Now let us come on to what is papule, what is plaque. I'll show you initially some images which will help you to differentiate between. Okay, this is papule and plaque. So papule is this, and confluence of different papules will lead to plaque. Okay, different papules join together to form plaque. So that's what they tell here. The papule is a solid elevated region of the skin. Okay, papule is a solid elevation of skin, and if multiple or a broad papule or confluence of papules will lead to plaque. Okay, so different papules join together to form plaque. That's what is plaque and papule. We'll come to more descriptions. We're going to study few skin lesions now. What is bullae? We could differentiate with macule, nodule, papule, plaque, pustule, and vesicle. So bullae and vesicle is what we are studying. They are going to see much more lesions. So basically, what is a bullae? What is a bullae? It is well circumscribed, definitely. Elevated. Bullaes are elevated. Okay. Fluid fill lesions. Remember that. These are fluid filled. So there are elevated lesions which are not fluid filled. There are elevated lesions which are fluid filled. So if they are elevated fluid filled lesions, they are bullae, but not just that, greater than 1 centimeter. So same thing, if less than 1 centimeter, it is called as vesicle. Okay, so if there is an elevated fluid filled lesion greater than 1 centimeter, it is called a bullae. If it is less than 1 centimeter, it is called a vesicle. We'll come to that. Okay. Examples, you know it, epidermolysis bullosa, whatever lesions you see. They're just seeing some examples here. I've taken it from one of the presentations, so the examples are not very typical of what you have to know here. But yes, you know vesiculobullous lesions, bullous impetigo and all those. Okay. Now, macule again is circumscribed, flat lesion, not elevated. Okay, you're going to see flat lesion, you're going to see elevated lesion. Here it is flat lesion, not elevated. So there is no fluid filled. It's a flat lesion, okay, which up to 1 centimeter, not greater than 1 centimeter, up to maximum 1 centimeter, okay, and which is not, it's a flat, so it's not palpable, definitely. Ash leaf macules, you'll study this, it's important. Cephaloid spots. Where do you see ash leaf macules? You would have studied it already. Tuberous sclerosis. And where do you see cephaloid spots? Neurofibromatosis, isn't it? Neurofibromatosis. Ash leaf and tuberous sclerosis. Okay. Now, so we studied one which is elevated, fluid filled, greater than 1, less than 1. Now we saw flat macule. Okay. Flat macules, flat lesions. Well circumscribed, nodules are well circumscribed, elevated. They are elevated. Solid lesion, not fluid filled. Solid, there is what is inside that, it's solid. Okay, if it is fluid filled, it can be either vesicle or bullae, depending upon the size. If it is solid lesion, elevated, it is going to be a nodule. Up to 2 centimeters, very big now. It can go up to 2 centimeter. Example, cyst. Okay, a cyst can be a nodule. Okay, now papule and plaque and pustule is very much related. See the arrow, the blue arrow marks there. Papule, plaque and pustule is related. So what is papule? Circumscribed, elevated, solid lesion. What is the difference now? Up to 1 centimeter. So if it is elevated, solid lesion up to 2 centimeters, it's cyst. Up to 1 centimeter, it is what? It is going to be a papule. So what is plaque? Plaque is confluence of different papules now. Okay. So again, so we saw solid lesions, fluid filled, can be vesicles or bullae depending upon the size, greater than or less than 1 centimeter. Then flat macule we saw. Nodule, what is that? Elevated but solid. Up to 2, nodule. If it is up to 1 centimeter, it is papule. Okay. What is plaque? circumscribed elevated plateau-like lesion. Okay, kind of a plateau is there. Okay, that is a slight bulge outside. Plateau-like lesion, solid lesion basically. Okay, greater than 1 centimeter. Now, difference between nodule and plaque. I'll show the image now. Okay, this was papule. The first one. Okay, before that, macule and patch. So flat lesion. Now another thing which is not described there. We studied flat lesion is macule. Flat lesion less than 1 centimeter is a macule. Greater than 1 centimeter is a patch. Okay, so only two lesions are flat, macule and patch. Patch is greater than 1 centimeter. Okay, then you have got papule. So vesicles, bullae, they are not solid lesions, they are fluid filled. If it's small, it's vesicle. If it's large, it's bullae. Now, solid lesions are what? It can be papule, plaque, or nodule. So papule is what? Just an elevation, which is much small. Okay, slightly bigger, 2 centimeter. Okay, it's plaque. Nodule, see the feature there. It's a more kind of an, no, it's not a direct elevation. That's the difference basically between nodule and a papule. Okay, so that's the nodule, which is up to 2 centimeter. Papule is up to 1 centimeter. Plaque greater than 1 centimeter. Now see, you don't need to exactly know what greater than, less than. So just know the difference. Elimination is much more important. They can give you this definition. You'll see different in different books. But once you understand the concept, you know what is what. Okay, 1 centimeter, 2 centimeter. Vesicles will be very, very important. Greater than 1 centimeter and less than 1 centimeter is very, very important. Now, pustule is circumscribed, elevated lesion filled with fluid. What fluid it is? Pus, purulent fluid. Okay, less than 1 centimeter. So, vesicle is also elevated lesion. So, now see. Bullae is elevated, fluid filled, greater than 1. Vesicle is less than 1, but both of them doesn't contain purulent fluid. That is, there is no pus. Whereas when you come on to the pustule, it is the pus which is there. Okay, purulent. That is what is the one which you saw. That is this one, the halotype, isn't it? The halotype is pustule basically. So it's a more thickened fluid. Okay, more thickened fluid. So that's what is the pustule. Then you have got the vesicles. It's circumscribed, elevated, fluid filled lesion up to 1 centimeter. Now, very simple way, I'll tell you. Flat lesions are macules or patches, less than 1 centimeter, greater than 1 centimeter. Okay. Then you have got the elevated lesions, the papule, plaque, or nodule. Okay, papule is very small. You can take it as less than 1 centimeter or up to 1 centimeter. Plaque is up to 2 centimeters. Nodule again 2 centimeters, but there is a slight difference here. Vesicles and bullae basically fluid filled, but it's not a purulent fluid filled, and the difference is 1 centimeter and greater than 1 centimeter. Okay. On the next lesion after pemphigus, we're going to discuss this pemphigoid, and there are two major types of pemphigoid, which is cicatricial pemphigoid. Okay, and there is bullous pemphigoid. This cicatricial pemphigoid is also known as mucous membrane pemphigoid, which involves mucous membrane more commonly. Okay, like the pemphigus, but not as such as pemphigus vulgaris. Okay, so like we have seen 95% cases here. It's not as common as pemphigus vulgaris. Okay, or the other name is ocular pemphigus. Now we saw that in pemphigus, the ocular involvement was very minimal or very rare. Here you will see that ocular involvement is the most problematic thing, and thus it's called ocular pemphigus. Okay, ocular pemphigus. Now, don't confuse. Ocular pemphigus is basically cicatricial pemphigoid. Now again, it's an autoimmune disease, so autoantibodies are directed against, which is basically IgG, directed against two major antigens of hemidesmosomes. So desmosomes. So hemidesmosomes connects what? The epithelium with the, or epithelial cells with the basement membrane layer. Okay, basement membrane layer. So against two major antigens, what are they? Pemphigoid Ag2 or antigen 2, pemphigoid Ag2, also known as BP Ag2. Now don't confuse bullous pemphigoid which is the next pemphigoid, BP. Okay, we'll see again BPAG2 there also. So it's BPAG2, basically we're discussing about what? Mucous membrane or cicatricial, where we'll see BPAG2. This is a big confusion people will have. BP, they will correlate with bullous pemphigoid. Basically this is mucous membrane pemphigoid. So it's pemphigoid AG2 or BPAG2, and there is epilegrin, another component of hemidesmosomes. So these are components of hemidesmosomes. Previously we saw desmoglein 1 and 3, components of desmosomes. So pemphigoid AG2 and epilegrin, they are also known as laminin 5. Okay, very important. So pemphigoid AG2, epilegrin, or BPAG2, laminin 5. Okay, so these are the antigens or the antibodies directed against these antigens. Okay, now there is an involvement of a particular receptor. You will see the latest editions of oral pathology Schaeffer's. You will see that there is certain receptors being affected. There is IL-4, interleukin-4. You know now IL-4 receptors and all. General pathology. Okay, you know now what it is. Okay, isn't it? You might not be knowing all the descriptions. IL-4 receptor, you know it. Interleukin-4. We have studied different interleukins. So IL-4 receptor. Typically, IL-4 receptor A number is it A1902 A bar A. Okay, just remember it now. See, you doesn't need to by heart it. Okay, it will just revise it. It will stay there. They might not ask you A1902, A1903, 4 and all. They'll just ask you IL-4 receptor probably. If at all they want to go deeper, they might go for IL-4 receptor A1902 A bar A, IL-5 receptor, like that. So you don't need to be very specific on this. Okay, so just know that receptor is affected in pemphigoid. Which pemphigoid? Mucous membrane pemphigoid. Two antigens, AG2, epilegrin or laminin 5. Okay, now, so this involvement of interleukin-4 receptor is seen in 90% cases. So that's the reason why it's so important. I've described it. Okay, in 90% cases. Now, very, very big difference between pemphigus and pemphigoid. Pemphigoid here with the scar formation. That's why cicatricial name, scarring. Okay, cicatricial pemphigoid heals with the scar formation. Now, oral lesions are very important, but not as common as pemphigus vulgaris. Here you will see vesicles or bullae. We saw that in the pemphigus vulgaris, vesicles or bullous are less common. We saw what? Ulcers, isn't it? Erosions and ulcers are more common. I show you the picture. Here it is much more common as vesicles or bullae, like the skin. Okay, and that is unlike pemphigus. Okay, pemphigus vulgaris typically, and then bullae becomes converted to ulcers definitely, and which is painful. Then you see desquamative gingivitis. Please note, desquamative gingivitis is not a typical lesion seen in pemphigoid or pemphigus alone. It's seen in different lesions. I'll come to this in the end of this chapter. But know that it is seen in pemphigoid or mucous pemphigoid plus pemphigus vulgaris plus lichen planus. So the lesion we studied, pemphigus vulgaris, it's there. This one, it's there. We're going to see lichen planus. That's also there. Now I'll come to a little bit deeper into this later on. Okay, so just know what is more important here is pemphigoid, mucous membrane pemphigoid is vesicles or bullae is more common here. Okay, rather than the ulceration. So you can see here. Okay, I'll come to this ocular sign. So this, see this oral mucosa. It's not ulcer. It's a bullae, isn't it? It's a bullae. It's a bullae. So now, if they ask you a question on the vesiculobullous lesions, and they say that vesicles or bullae, it's more commonly the mucous membrane pemphigoid, not pemphigus. If you're confused between pemphigus and mucus or pemphigus vulgaris and mucous membrane pemphigoid, please note mucous membrane pemphigoid has got bullae, whereas pemphigus vulgaris has got erosions and ulcerations. Okay, so I'll come to that later on. I'll come to this ocular lesions now. Desquamative gingivitis typically, okay, which is seen in these mucous membrane pemphigoid as well as pemphigus. Okay, so it's basically vesicles and bullae. Now ocular involvement, very crucial. That is, it's the most serious complication of mucous membrane pemphigoid, okay, or cicatricial pemphigoid. What you see, the first thing you see is symblepharons. The term is important. Symblepharons. What is it? It's adhesion between the two conjunctivas of the eye, that is bulbar and palpebral conjunctiva. If you want to see the bulbar and palpebral, See this here. This is the one I'm shading now is the bulbar conjunctiva. It's turned around, and this the other end is called the palpebral. Okay, or you can see it marked here. This is the palpebral conjunctiva. On the other side, inner, you have got bulbar. So it just get adhesions and scarring. So just imagine, it's going to be very difficult. Okay, the eye opening becomes very difficult. Conjunctiva gets scarred. Okay, that's what is known as, what is the name of that? Symblepharons. Adhesion between bulbar and palpebral conjunctivas. Now, entropion, that's another name for eyelids turn inwards. So see, there's the inward turning of the eyelid. Okay, and finally you end up in blindness because of scarring. Okay, there is blindness because of scarring. So basically, ocular is most serious. One is symblepharons, entropion, inward turning of the eye, and finally blindness. So blindness is more common in which pemphigus or pemphigoid? It's pemphigoid. Scarring is more common. See this. So this is again, this is the entropion. Upper eyelid, it's more clear. Upper eyelid is turned inward, isn't it? Now here you have seen this. Okay, this is basically a conjunctival environment, conjunctivitis. Okay. Then there is the trichiasis, hypertrichosis. That is the eyelashes hit on the eye and which causes problems. So it can also be seen. Now here, this is the eye scarring. Okay, symblepharons and scarring. Okay, finally end up in blindness. So what did we studied so far about this pemphigoid, mucous membrane pemphigoid? Antibodies are different, BPAG2 and epilegrin. IL-4 is there. Then oral lesions are vesicles or bullae. Then finally we come across ocular lesions are much more problematic, symblepharons and entropion, ending up in blindness. Now histopathology is also equally important. There we saw suprabasilar split. Here we saw subbasilar, I would say subepidermal, below the epidermis, entire epidermis split, because hemidesmosomes are affected. Subepidermal split. There is no acantholysis naturally because there is no involvement of spinous layer. So there is no acantholysis. Basement membrane zone immunofluorescence, again due to involvement of hemidesmosomes. Okay, that is, basement membrane appears to be detached from the overlying epithelium. I'll show you the image. Okay, and this will produce direct immunofluorescence. That is, antibodies, you take the lesion, okay, and you like send it for immunofluorescence. You will see that there is immunofluorescence in the basement membrane zone. There is a picture here. Yeah, this is the immunofluorescence you see. This is the basement membrane zone. Okay, this is the basement membrane region. So below that, this region is the connective tissue. This is the epithelium. So in between that two, there is a basement membrane zone, the immunofluorescence. This image can be asked as a question. So now here it is. This is the epithelium. This is the connective tissue. And in between you see this as a split. Okay. There it was somewhere here. The split was in the pemphigus vulgaris. The split was supraepithelial, or I would say suprabasal. Okay. So that's the direct immunofluorescence. What about indirect? Indirect means in the blood. That's negative. Indirect immunofluorescence. Please note, it's negative in mucous membrane pemphigoid or in pemphigoid. Okay, that is, there is no circulating antibody. You will see only antibodies in the lesion against the basement membrane. They doesn't detach and go to the, this antibodies doesn't detach and go to the circulation. So very big differences. Okay, pemphigus, there is direct immunofluorescence and indirect immunofluorescence. Here, though indirect is 80 to 90, here it is, indirect is completely negative, there is direct only. Okay, and what are the antibodies, you know now. So that was the pemphigus and pemphigoid, very important. Pemphigus antibodies are different, isn't it? That was desmoglein, here it is epilegrin. Okay, epilegrin and the BPAG2. Okay, then IL-4 receptor is more common here. Here the lesions of oral cavities, different vesicles or bullae. Okay, and then ocular is very problematic here. And finally, you end up, there is indirect immunofluorescence is negative here. Okay, only direct is positive. And that too in the region of basement membrane, not suprabasal. Now next we come on to bullous pemphigoid. So we studied mucous membrane or cicatricial scarring. Here there is no scarring. Okay, that's one big difference. Okay, that was cicatricial, which was scarring with ocular involvement. Let's see here what you're going to see. It's the most common autoimmune blistering condition. Not oral cavity, okay? Here oral involvement is very low. If they ask you most common autoimmune blistering condition, as such, it is bullous pemphigoid, okay? Now, autoantibodies against hemidesmosomes, both of them, but hemidesmosomes of bullous pemphigoid antigen. That was mucous membrane pemphigoid antigen. Here it is bullous pemphigoid antigen. Both of them against hemidesmosomes only. Okay. Now the name of the antigens are different. BP230, bullous pemphigoid 230, or BPAG1, BP180. So it's 230 and 180. Okay. So 180 is known as BPAG2. So there also we saw BPAG2. So your textbook Schaefer says both of them are BPAG2. Anyway, just know the names are. The other names are different, definitely. Come to this, which is pemphigoid antigen 2, okay, and epilegrinolaminan 5. Okay, here you come to this one, it's BP230 and BP180, AG1, AG2. Okay, 230 and 180 is important. Now, heals without scar, I told you, because it's not cicatricial. Rarely involves mucous membrane. Subepidermal splitting, the same as that, because hemidesmosomes are involved. Okay. Now note, both type of pemphigoid are due to autoantibodies directed against what? Basement membrane zone hemidesmosomes. This again, just for an MCQ perspective. Okay, basement membrane zone immunofluorescence is seen in what? Both type of pemphigoid. So that's the end of today's session. We have more to discuss. Lichen planus is there, then lichenoid reactions is there, then you have got erythema multiforme is there, then you have got the SLE also. So we'll discuss them in the next session.